Hi, everyone. Thank you for attending last uh, this last webinar of the Disorder of Consciousness Special Interest Group, the DocSig of the IBIA, before we jump into summer. And we hope that it will be inspiring for you. It will be on machine learning in disorder of for application for disorder of consciousness. Sorry, diagnosis and prognosis in pediatrics. This is Erika Molteni, who is a member of our group, who will talk. And to introduce her, she is a medical engineer. Dr. Molteni is a biomedical engineer and lecturer in health data science at University College London, specializing in data science for pediatric neuroradiology and neurointensive care. After a master in science in biomedical engineering and a PhD in bioengineering from Politecnico di Milano in Italy, she has focused her research on utilizing or using, sorry, I cannot say that word, neuroimaging and neurophysiology to understand consciousness recovery in children post-coma. So Erika, thank you so much for accepting presenting on this very interesting but also kind of technical issue. As Erika told me in the beginning of her presentation, it will be a little bit more technical, really to introduce the technique, and then she will talk about applications. So just for you to know, that will be a good mix between both. If you have any question, as usual, write it in the chat, and we'll make sure to ask those questions in the end during the 10-minute Q&A. Okay, Erika.
Thank you very much. So let me share my screen, but not before having thanked, first of all, IBIA for inviting me, and second, Caroline for having thought of me and for following up frequently on my activity and inviting me several times in these occasions. It's a pleasure for me to be here today. So good morning, good afternoon, everyone. I will share my screen and maybe in presentation mode so that you can see it at full in full dimension. All right, so in this hour, I will present this topic, which I really like, which is the application, the employment of machine learning in disorders of consciousness with a particular interest in children, which is indeed my specific field of interest. And what I'm going to say, and this was already anticipated brilliantly by Caroline, I will try to introduce some useful concepts around machine learning, trying to keep it very simple. So I hope you will enjoy it. And I hope that it will leave something at the end of this presentation in terms of knowledge. And then I will try to integrate these concepts inside the domain of disorders of consciousness. And I will also try to explain which, in my opinion, are the peculiarities that apply to children only. And so the issues that we see specifically when dealing with children and applying machine learning to disorders of consciousness for children. And last, I will provide my view, my opinion on the potential impact of machine learning in this field from here on. Okay, so I would like to start by giving a bit of vocabulary, if you like, and definitions. So we are in the domain of data science, which is a big science which deals with all what is about data and data processing. And in this domain, we have a big subdomain, which is artificial intelligence, a term which is very often used in journalism and on the media, not much in the preference and as a favorite terms for the more specialized and technical people. And that's because artificial intelligence basically refers to anything which can emulate the human reasoning, but it's a very general term. And when we move to machine learning is where we become a bit specific about applying models to to data, and particularly deep learning is the sub-science, let's say the subfield, which applies models to really delve in depth into the characteristics, the features of data to make decisions. And this is normally, but not necessarily, done through artificial neural networks. So if we want to summarize really the difference in between these core three terms, artificial intelligence, machine learning, and deep learning, artificial intelligence is a broad term which defines whatever mimics computationally the human intelligence and the human reasoning. For example, a workflow ideally is artificial intelligence. Then when we move to models, we move to machine learning. And we move to the use of models to make decisions by looking at patterns in the data. And when we use artificial networks to reach accurate conclusions on the data, then we are in the domain of deep learning. So I hope that now these terms are kind of unequivocal. In practice, there's another difference in between machine learning and deep learning that I want to explain with this very simple example. So let's imagine to have an image, for example, the image of a car. So what machine learning does is it is a science around creating models to make decisions, for example, reading digitally the image and saying, well, this is a car or this is not a car. But there's the assumption that the information which flows into the model might not be the image, the raw image per se. So we assume that there's a human agent or oracle, as it is called in the field, who will extract features and pre-process the information, in this case, the image of the car, in order to really provide the model with the information in a format which is useful to the model to make a decision. Deep learning is the science of end-to-end solutions, in the sense that we give up the human component and we ask the algorithm to self-decide which are the characteristics of the raw data that can be useful in order to learn how to make decisions, and to self-prepare and to self-learn how to make the best out of the information which is available in order to learn to take decisions. So, in a way, this is self-standing, if you like. So, of course, it's also very interesting to see how mathematics organize in itself to perform this task independently from humans. And coming back one step in terms of looking at machine learning in general, the next question is to say, okay, how is machine learning working in healthcare in general? Well, what we normally see is that researchers working in this field leverage on all the information which is present in a hospital or in a healthcare setting, and search for strategies in order to input this information in the model and train the model to learn how to make decisions. So we leverage demographic information, clinical information, radiological information, meaning images, treatments, and also information which is pretty complex, such as, for example, video recordings in a surgery room, or trajectories from assistive robotic devices and things like this. And of course, you need some pre-processing in order to extract that part of the information from each source which can be useful to the model, and ask the model to learn how to decide about a specific problem. The other aspect is that the decision the model can make is very specific. We can't really ask generic questions as humans would be able to do. So we need to really ask for detection tasks, classification tasks, prediction tasks. And so the way we ask to learn how to make these decisions is we ask the model to learn, and the next question becomes, okay, but then how is the model learning, right? How do we make mathematical model learn? So we can only leverage data, which means that basically we can subdivide the data that we have available into a part of data that will be used for training and a part of data that will be used for testing. And this is because we want to keep some data apart in order to really verify that the model has learned correctly on the data available. And we do this by testing on data that have never been seen by the model, to which the model has never been exposed. The fact is that it's not sufficient that we take a model and we expose the model to the data just once. Usually this is not what we would do. What we would do is to further subdivide our pool of training data into further subsets and ask the model repeatedly many times to consider different subsets of these data and self-control, self-assess whether the model has adapted correctly to the specific combination of data it has just been exposed to. And depending on how much the decision the model can make is good with respect to what is the reality, the response we already have in the data, which we call the ground truth, then we can tune the mathematical characteristics of the model, which are called the parameters. So basically, we repeat the training by reshuffling the data and exposing the model to different combinations of the data many times in order to optimize this mathematical formulation of the model. And once we are done, we then expose the model just once to the data that we have kept apart, because these are ideally the data of our next patient, the data of someone in the future that the model couldn't learn on, but we want to really use the model for. And so that's the importance of the testing data that we keep apart until the end. So this is a kind of design of machine learning training, let's say, that is found in many papers, and I hope that now it makes a little bit sense to you, and you will remember this when you read it through a paper. In terms of deep learning, the type of model that is applied is very often a neural network. A neural network is such a model in which we have different layers of mathematical processing, which means that basically we have an input layer, which is in contact, let's say, with the information, with the raw information that we pass into the model first. And then we have a number of intermediate layers that we call hidden layers, because actually they are never exposed neither to the input nor to the output. And then a final layer, which is the closest to the decision making, which is the output layer, the one in charge of really taking care of how the decision is made in a way. So how does this complex thing works? Well, conceptually, it's very easy. So each of these dots is what we called a hub or a node inside the network, and it's a mathematical operation. And so we take the input, we move the input into this network of mathematical operations, which are connected in between each other through connections or edges. And when we do this computation inside the network, what we care about is to optimize the connection in between these mathematical computations in a way that there will be a weight in between them. And it's all about testing different combinations of weights in between these different layers of mathematical computation, so that in the end, the decision that is taken is the most similar to what is the reality, meaning the ground truth, meaning the answer we have for our model. So this is how it works, and you will also understand why these networks or models are trained, we say, in an iterative manner, meaning that I have to learn from the data many times to optimize, to fine-tune these little, let's say, these little functions, mathematical functions, which are a little bit like the hops in a stove or in an old television. We have mainly 4 neural network types. This is a cheat sheet, which was produced by Fyodor van Veen a few years ago. It seems very complicated, but basically it can be summarized depending on colors. So you see some networks which are prevalently green, some of them are prevalently blue, and some of them are prevalently pink. So let's start with the green. So the idea here is that the information enters in a network and then it flows like a stream or a river. These are the feed-forward networks, and these type of networks are networks which process the information as it comes in. So you have a flow of information in, a processing, and a decision which is taken. These are the simplest network design. This is the simplest network design. Then we have a second type, which is the ones with the blue dots and a little curly thingy on top of that. So these are networks which accept an input, retain an input, and accept a second input, and enable us to process differentially different inputs which enter at different time points. Indeed, these are called the recurrent networks, neural networks. And this is the way, basically, we mathematically build the ability of a network to have a memory. And it's not by chance that these networks enable us to process longitudinal data or signals or information that has a time relationship. And that's because you can really input information, input some more, and then differentially process the information of different time points or different subsequent input points. And then we have a third type, which is the networks with the pink dots. And you will notice that they have a kind of pyramid and counter-pyramid type of shape. That's not by chance again, but it's because these networks called convolutional neural networks are mainly used for processing images or grid-like information. And this is because we want to extract different features from the information at different levels of the processing. So let's imagine we want to process the image of my face. In the first layer, we will be able to extract information such as, for example, the length of my hair, of the shape of my face, while in the second layer, we will be able to extract finer details like the shape of my eyes or the nose. And in the last layers, we will be able to extract even finer details like the texture of my skin. And by taking this compact representation of these features, still I can capture the information about how my face is without having the full image and the wealth of pixels of the image of my face. And then there's another type, which is the newest one, which is the attention-based networks, or to which also transformers belong, and large language models such as ChatGPT or DeepSeek. These are models which are more complex, and basically the idea is that these models can really identify patterns close in time, but also at like long-range connections in between different types, different modalities of data, and so they have become very, very powerful. So now we have an idea, basically, of the different neural network types, and we can also understand why different networks are applied for different applications and why the field of deep learning is apparently so complex, but in fact so obvious, so trivial. So going back to the previous point, one of the aspects that we mentioned is that a model has to take decisions, to make decisions. So the question is, which kind of decisions we can ask a model to take and to make for us? So the first and most common is the classification problem, meaning deciding whether a patient can be in different states, for example, of consciousness, whether a patient is in vegetative state or minimally conscious state, or in a severe disability, or that maybe. Or we can classify patients as probably recovering, probably improving, or non-improving in a prognostic manner. So this is about classification. This is the most common type of use that we do of the networks. One other type of problem we can ask is more computer vision. It's what we call segmentation. Basically, it's about finding shapes inside images. For example, detecting a tumor, or for example, detecting the area of a stroke. The third type of decision we can make is the detection of an anomaly. We are not asking here the network to detect what's inside a signal or what's inside an image. We are just asking to detect what's not common, what's not already seen frequently, what's infrequent, is a non-standard presentation with respect to the rest of the data. And this is how, for example, we detect remotely the falls in elderly in their domotic environment. But you can understand that in the domain of disorders of consciousness, this becomes very powerful in intensive care unit, for example, where you have a lot of information and you just need to detect pattern in the data that might indicate that the patient is going to evolve very rapidly for the better or for the worse. And then we have generative models. Generative models is really about generating new information. And you can use generative models for example, fill in the gaps of complex information that you don't have in clinical trials. For example, in filling the gap of an MRI visit of a patient who didn't show up or who couldn't show up due to the worsening conditions at a certain point of time. And we can also use generative models to generate new patients synthetically. And we will see later on in this presentation how it can be useful. And it's not just for fun or for didactical purposes, but it can be also really useful to science. Now I would like to give another concept which I hope will be useful for you to understand, for example, the papers that we read about machine learning, which is the difference between supervised and unsupervised learning. So for explaining this, I will start from a very didactical and basic pedagogical example. So I hope you will forgive me for this. So I'm showing here a number of animals. We have owls and foxes and squirrels. And the idea is that if we have some images about owls, squirrels, and fox, where we can tell to the algorithm, well, this is an owl, this is a squirrel, this is a fox, then we can help the algorithm learn which are the characteristics peculiar to the squirrels, the foxes, and the owls. So that if then we give some images which have no label, for example, an image of a new animal with the wings and big eyes, then the algorithm can say, oh, well, based on the information I already had and the fact that all the animals with big eyes and wings were labeled as owls, this is most likely to be an owl. And so this is how it will label my new image about the owl. And the same, of course, for the fox and for the squirrel. So now moving to our field, which I think is what we want to do, but I hope this was useful to understand. If we have a pool, for example, of images about stroke, encephalitis, and TBI, and we can label some of them saying, this is a stroke, this is encephalitis, this is TBI, then we can hope that under correct mathematical conditions, the algorithm will be able to detect as either stroke, encephalitis, or TBI new images that we are providing to the algorithm. And so the correct classification will be done. In unsupervised learning, we don't have such labels, meaning that we can't tell the algorithm, well, this is stroke, this is TBI, or this is encephalitis, for example, because we are leveraging a big database of a hospital where this information is not linked, where the clinical notes are not linked to how we have saved the MRI information inside our radiological database. Maybe we have 1 million images. So how are we going to go about that? We can't really ask a person to, a radiologist to go back and look at 1 million images. So what we can ask the algorithm is to work in an unsupervised manner, meaning to just cluster, basically, images depending on their characteristics, and to pull together images with certain characteristics, other characteristics, and other characteristics. But importantly, the algorithm per se will never be able to say, this is TBI, this is encephalitis, it will only be able to group them. But then you will need a human, again, an oracle, as we say, who, from their expertise, will be able to say, well, this is a group of TBI images, this is a group of encephalitis imaging. However, mathematics is never, it doesn't reason as humans necessarily. And so you might have surprises. For example, you might see unusual presentations of TBI pulled apart with respect to the rest of the TBI images, or unusual presentations of stroke subdivided into maybe, I don't know, monolateral stroke and bilateral stroke and so on. So it is really important to look at this pool of images and understand whether these partitions are done correctly. But importantly, we can also discover, for example, rare diseases or rare presentations or rare patterns or radiological patterns inside images that might not have been described as such in the literature. And of course, as applied science is never an exact science, we also have midway solutions. We have what we call the semi-supervised learning, in which we have only few labels available, or only partial quantity of data is labeled. So in this case, we can ask the algorithm to label what can be labeled and pull apart what remains. And then again, we have this game of having an oracle, having to go through what hasn't been labeled, and deciding what was taken apart. And this is how, for example, we discover unusual patterns in radiology in a systematic manner. There's also another type of learning, which is called active learning, which I'm not going to show today, which is even more specific. We constrain the algorithm to label everything anyway, apart from those images or those pieces of information which make the final performance of the algorithm decrease the most, or which introduce the most uncertainty, for example, in the data. And we ask then the oracle to systematically label only those images. And this is a strategy in order to maximize the improvement in performance of the algorithm by minimizing the labeling effort of the human resource, the radiologist, for example, who's in charge of doing that. But this is already kind of advanced domain. Okay, so how can we apply supervised, unsupervised, and semi-supervised learning in the domain of disorders of consciousness? Because this is our problem. Okay, so you will have understand then supervised learning is basically about classification. So we can classify the status of a patient, ideally. So disorder of consciousness, the consciousness level, but also diagnostic classifications in terms of presence or absence of a certain condition or a certain complication, which is not obvious or trivial to the eyes. We can also use supervised learning in terms of finding biomarkers, for example, biomarkers of unusual presentations, or biomarkers of certain certain stratum of the patients that is not commonly observed in clinics or used by the clinicians, but we see that mathematics uses exactly that feature in order to make the decision, to make the final classification. So it's very convenient to discover basically new patterns into the data. Unsupervised learning is used for patient stratification very much, and for, as we said, endotype discovery, meaning pulling apart groups of similar patients and then going back and seeing what's the original information, what is shared in the original database about those cases which were grouped beyond the pattern that caused the grouping or led the grouping, drove the grouping. And then it is very much used for dimensionality reduction, meaning reducing the number of information that we have to consider. This is particularly important in areas like intensive care unit, where you have a huge amount of information and the clinical staff might not necessarily be able to consider them all at the same time. And so dimensionality reduction is basically looking at those features of the data and those characteristics of the data that most contribute to making the decision to most contribute to the algorithm to mathematically say this patient is classified like this, or this patient falls into this group of data. And then we have the semi-supervised methods, which are less used, but have great potential for optimizing the human resources, minimizing the labeling effort, reducing the annotation burden, and especially enhancing the early detection of patterns that then, in a purely supervised manner, are given to the model to be learned much later on in the history of the patient. So basically, we can hope to identify early indicators of what is normally detected and labeled later on in the clinical pathway. And here you have some examples of literature that basically does this. One other concept that I would like to explain is the concept of transfer learning and fine-tuning. And I think that in the domain of pediatric disorders of consciousness, this is crucial. So transfer learning is about having little pool of data that we call the target data in green, and being basically unable to obtain good performance of for the algorithm to make a good decision on such a small set of data. So if we have too few data, how can we go about this? How can we do? So the strategy that the field came up to is basically to take another bigger pool of data on usually on a more generic problem where you have more data, and train the same model and calculate the best parameters for that more general problem first. And then after this model is trained, use the new smaller data set, the smaller data set that is new to the network, but it's related to your original specific problem, and to end or conclude the training of your model, or further refine or fine-tune the training of your model through these more specialized data. And the idea is that if you find a good trade-off in between maintaining certain generalizability given by the previous more generic model and data, and specializing a little bit towards your specific problem under correct mathematical assumptions and in correct data condition, you can obtain performance which is much more than both training on a more general model and then applying that model straight to your specialized data, or just training on your specialized data. So basically, this joint venture in between generalizability and specificity gives better results with respect to either of the two. Why is this important for children? Well, because sometimes we have very small data sets with children, and so why not to train on bigger databases with adults in disorder of consciousness and then try to specialize on the few cases that you have at hand for children. And also, it could be a matter of etiology. For example, let's imagine you want to study the disorder of consciousness in stroke in children. That's relatively rare, luckily. So why not to take severe stroke in adults, train on a bigger pool of strokes, and then go down to your specific data on children? So this is the type of use you can do of transfer learning, and I think it has great potential in this specific field. One other concept I want to give is that of the foundation model. I'm mentioning it here because it's a big hype at the moment. Everyone is speaking about foundation models. This is about taking a lot of imaging modality and text modalities and other type of data such as wet lab data and omics, transcriptomics, genomics, putting all together and then hoping that you create a kind of super model that can be specialized for different type of tasks, from creating chatbots for clinicians in the hospital up to discovering population health new clues or insights. Well, this is obviously very ambitious, and one could think about applying such type of models to this problem. Of course, it is important to know what it is, and that's the reason why I'm mentioning it. It's probably a bit early for this little domain of the pediatric disorders of consciousness to think about these kind of more generic applications, because these applications normally need really a lot of data for performing these tasks and refining towards different objectives. But for sure, in other domains, such as, for example, adult stroke or Alzheimer's disease, these are very promising. So I promised before to spend a couple of words on the concept of digital twin as well. So the idea of the digital twin is to create a digital patient, which is a twin of your real patient. And the idea is to be able to be free of creating experiments for your patient without harming them. And for finding the best solutions for them, or trying to make them evolve towards potentially resolving, but also potentially risky interventions, or pharmacological dosing, or even surgery. And the idea is that you have to somehow have all the data at hand, which are at the interface between your question and your problem, and the biology and the physiology of the patient. So, for example, if I want to test the pharmacological compound, a drug, I might want to have information about the exams of the dosages of certain proteins or molecules in the human body that interact, neurotransmitters that interact with that particular drug. And by having this information about your patient and information about a pool of previous patients that, for example, got that drug for other reasons and with other pathologies, you can hope to really simulate, in a way, the behavior of your patient, but not necessarily by setting up a full mathematical simulation, but rather by just delving into these kind of big libraries of data that you have and finding the patterns that are most similar to the condition of your patient that you have at hand. So the idea is that you can experiment, for example, a range of pharmacological treatments and see what's the best one for the patient, or you can experiment a bit of different surgical techniques and see what could work out best for the specific problem. And of course, you can think at different applications and cases for your specific scientific question. Of course, there's a lot of math involved, and especially very often we need to work at different scales. For example, from the omic scale up to maybe anatomical scale if you have to work on accesses or interventions. But let's say this is a very promising field as well for certain type of medical decisions. And maybe the really last concept I want to give about machine learning is that of reinforcement learning. This is very much understandable in the domain of neurodevelopment of the child. So how is a child learning about their actions and the knowledge of themselves and their actions in the environment? Well, they perform an action, for example, trying to grab the mom's necklace. And then they just try randomly a trajectory for their hand, and then what they learn from is the difference in between the planned action and the result of the action in the environment. And depending on whether the error is big, there will be little reward. If the error is small and the child manages to grab the necklace, then the reward is high because you have your mom. So the same idea here is applied to robotics, basically, and this is how robots learn to interact with the environment. So why not to use this concept, for example, for rehabilitation of patients in a disorder of consciousness? So the idea is to perform a trajectory, see what happens with that planned trajectory, whether this is the effect of this trajectory is what is intended or not, calculate the error, give a reward to the robot, and then ask the robot to try another trajectory and see the effect, compute the reward, and so on and so forth. Of course, you can perfect trajectories in a static environment, but you can also adjust your learning in a dynamic environment. So that, for example, if you move your patient with your exoskeleton from the lab environment outside to the yard of the hospital, and the type of pavement and the type of flooring is different, the exoskeleton can learn dynamically to adjust the stance of the steps of the patient in a dynamic manner. And so this is a concept which is useful, not really maybe in acute, but for what is the robotics and the rehabilitation around the patients with a disorder of consciousness. Of course, in the case of children, as they have shorter arms, lower weight, you need to be extremely precise, more precise than in adults in the calculation of trajectories, these differences, and also rewards. Right, so the next question is, what is already out there? A bit of machine learning in pediatric disorders of consciousness, it is there, it exists. And what it has been demonstrated up to now is that it is possible to classify the disorder of consciousness, the state of consciousness, sorry, for children, both for diagnosis and for prognosis in 3 months' time, for example. But it's always difficult to say everything has gone right, the right way. We have also seen and demonstrated that the state of consciousness, which is the most difficult to be predicted, is the minimally conscious state, which is probably the most crucial. The problem is, this is in children is usually a transitory state, a transient state. So if the patient progresses from the vegetative state to the minimally conscious state, then they progress further. So we have little cases, and usually the cases in minimally conscious state in a database are very small, a very small pool. It's what we call technically a minority class. And this obviously puts an additional constraint to the algorithm, because it's the most difficult case and also the case where you have, it's the most difficult class and also the class for which you have the smallest number of cases to learn from. So, but this, this is something. And the other aspect is that we have applied a bit of machine learning to understand which are the patterns in sleep that are the most indicative, if any, prognostically. And the result is that the modulation of beta activity in between sleep and wake seems to be the most promising biomarker. But unfortunately, this is a work with the big limitation that we had no validation data set. And so, I mean, I would take this as a very preliminary result, but still an indication. And unsupervised methods have been applied for clustering trajectories and for seeing how children are recover or are rehabilitated towards better outcomes with a rehabilitation program, which is a standard one. And what we observed is that mathematically you can kind of demonstrate pretty robustly that we can disentangle in between 4 trajectories, basically. And this has been incredibly useful also to try to understand which are the underlying causes of non-responding to rehabilitation. And for example, in this work particularly, we observed how the presence of epilepsy is the main obstacle, apparently, to perform better during rehabilitation. Okay, so now I would like, in the last minutes, I would like to go through what I think, so here we enter in the domain of my personal opinion, what I think are the main, let's say, the main peculiarities in the domain of pediatric disorders of consciousness, what is really critical in children. So the first point is that we know that there's an optimal point where the model can be trained. So if the model is undertrained, we will have biases due to the fact that the model hasn't learned sufficiently. If we overtrain, the risk is that of having overfitting, and I will explain afterwards what overfitting is, but basically it's very bad because you're not able to generalize your model to new cases, to the next patient who will come into your ward. So what we really need is to improve the generalization of our models, instead to work on the ability of models to improve the generalization by other manners, and particularly with multimodal studies. I think that having multimodal information would help to some extent. But I think that there's a more basic problem in this field, which is collecting information which is consistent in between centers and in between studies and databases. And you will understand now that as we need a lot of data to train these models, these models more likely will use data from different centers. It is of utmost importance that the centers minimize the differences on how the data are collected. So this is what we call data harmonization. So it is important that we get to an agreement on how to acquire the data in a manner that is at least comparable. There have been efforts in this sense. The Curing Coma campaign is one, important with common data elements. IBIA, I think, has done its little part in the past, but for sure we have to keep the eyes open towards this. And I think that the training strategies I've already stressed on transfer learning will be very important in order to make the databases collaborate together towards the creation of a model and contribute in an unbiased manner towards the creation and the training of good models. We have the risk of local failures otherwise, meaning models failing when moved from one database to another one. And also we have a lack of longitudinal data for children. This is a massive lack. What does it mean to have overfitting or underfitting? Having a model in overfitting means that we have few data and the model learned very well to be very specific to those data, but too much. And when we give a new record of a new patient, the model doesn't know how to deal with that because it didn't learn the pattern, it just learned the data points, and that's too much. On the other hand, we want the model to learn certain characteristics of the population, so we really want to stay in between, in the right fit, so to be explicit enough and specific enough so that the model learns some peculiarities about the population we want to study, but not too specific so that you cut out other possible cases of the same population. And so for doing this, we really need to have the correct quantity of data. And if we have classes which are particularly imbalanced, meaning particularly scanty, such as minimally conscious state in children, then we can try to deploy strategies in order to counteract for this. For example, by synthetically increasing the number of data points for those minority classes. There are really a plethora of mathematical methods for doing this, but we also know that although these methods work and help to some extent, the model cannot improve in an infinite manner by just adding synthetic information. So the models at a certain point, they will plateau in their performance anyway, because if you multiply information but always striving from the same cases, you are not really creating such a huge new information to the model, just a bit, or just helping a bit the generalization, but it's not the solution to all the bad situations. So I encourage the use, but I also want you to kind of play down a little bit on the expectations. And last, I would like to spend a couple of words on the problem of working with small databases and with information which sometimes is not particularly designed for studies, but rather retrospectively extracted, or information which is a little bit taken from different historical periods. So we can have different biases in the data, which means different derangements with respect to what the reality is or would be if we had to consider an ideal real situation. Which kind of biases do we have inside our data? Well, for the case of children in vegetative state, in disorder of consciousness, I would say very much historical bias, because we have data mainly from US and Europe, and we've seen Western Europe, and we've seen TBIs going down, the road safety improve a lot, and encephalitis, autoimmune diseases increase. So we have these historical trends in the data of children that are intrinsically present in our data, and that can play an intrinsic bias. Also, we have what we call a representation bias, meaning most of the cases are white. We just have to recognize this, but we also should do something about that. For example, taking care of the minorities and enriching the data on the minorities synthetically until the data are not available yet in reality, and then possibly in reality, I would say. We also need to consider measurement biases. For example, if we apply the CRSR, we know it is overemphasizing the motor domain and the motor abilities of the patients with respect to other domains. This has to be taken into account because it could introduce a bias in the ability of the model to make decisions on the state of consciousness. And then we have aggregation biases due to the fact that we might put together databases with different sizes, acquired with different inclusion criteria or different admission criteria in the hospital. And then we also have attrition bias. Attrition bias refers to the problem of really seeing patients dropping out in longitudinal studies. And here we see tendentially different behaviors in Europe and in US, with the best cases falling out in Western Europe and more severe cases falling out from the studies in the US. And then, of course, development bias, where the model that is developed and how it is interpreted. So I really encourage all of us to think about these aspects when designing the studies and when writing the grants, in order to really maximize the quality of all the framework in which the models are presented. Okay, I also want to mention the fact that models have to be rated for their performance, and they have to be characterized for their performance. And it is important to use more than one metric in order to describe the performance of the model. And the models, if from machine learning and deep learning, they also need to be characterized for their ability to identify the characteristic of the information which flows into the model. And this goes under the name of explainability or interpretability or explainable AI. So we have methods, for example, for identifying which which features in the data contribute the most to the decision, such as SHAP or LIME. And we have methods to identify which patterns in the image are the most informative towards the decision. And this is very much used in computer vision, such as, for example, the GradCam, the use of inverse gradients for finding the patterns inside the MRI, for example, or the CT, which most contributes to the segmentation or to the final decision on the image. And last, I would like to mention that one important...
Just 1 minute or two, because then we'll have just 5 minutes for the Q&A, okay?
Right, okay, thank you, Caroline. Indeed, I kind of came to an end. So just wanted to mention that one aspect of this topic is to make the models trustworthy. So through trustworthiness in AI. And here I just put the link to the EU guidelines and the Canadian guidelines, and one paper which is specific to the medical domain, in order to have idea of what are the concepts that we need to apply in order to kind of certify the quality of our model and assess the quality of our model and make these models clear in their working modalities. Okay, so as I've already anticipated before, I think that the future of this field, and particularly pediatric disorder of consciousness for what concerns machine learning, is about conducting multicentric studies to increase the data size and to increase the generalizability. And here some techniques to make the database contribute to the final models might be needed to be applied. And I very much encourage procedural guidelines for data collection. We also need to take into account that data precision really depends on age, with data collected in children under 3 years of age, really seeing the precision of the data collected decreasing dramatically and rapidly. Of course, the assistive technologies will soon provide very big pool of data from little number of patients, because imagine having months of recordings from wearables in home environment. So we will need to deal with how to to label this information, how to use the human resources in a wise manner. And although I don't think there's, in principle, a need of specific networks or specific machine learning and deep learning architectures for children with disorders of consciousness, I think that what is important here is that the training strategies might be a little bit more refined in this field with respect to the field of adults with a disorder of consciousness. And this is why the pediatric diagnostic group has kind of gathered their efforts in order to answer this problem and say, okay, how can we help the field to improve the evidence of our research and models. And given that literature is about single cases, case series, we don't have big databases. And so the response is to say, okay, let's take all the cases available in the literature, let's build an overall big database for this problem, and let's release this to the community, to the scientific community, in order to be able to test the developed models on a validation set, which is really big and can really demonstrate the generalizability of the model and possibly raise the bar of the quality of the models which are produced. And so, especially related to this last aspect, I would like to thank all the people who have worked with us over these, I think, 6 years. And they have taken up this last challenge, and I hope this will serve the scientific community at large to make better science and possibly help a little bit more these cases.
Thank you so much, Erika. It was a very interesting presentation, and particularly with all the potential that machine learning and AI has to offer. I had a question related to treatment. So there are some more paper coming out using machine learning and AI to find new molecules that could be similar to what we have been using to treat patients with disorder of consciousness, and try to actually develop new treatments using what is already approved by the FDA. What do you think about these type of model, and what for you would be the advantage versus the caveat of using those model for that type of objective? Because as you know, treatment is kind of the poor, I mean, it's in development right now, but it really needs to reach a new boom, and it looks like we are about to be there. But using that tool would be like wonderful. But in the same time, you know, I would love to know what would be your opinion about caveat and things like that.
Well, this is a very good point. I think that there will be definitely a push towards this, and we will not even need to encourage this, because for a pharmaceutical company developing a new pharmaceutical compound or new drug, the enterprise is immensely costly and immensely risky, because we see how many trials fail in a very late stage, despite
Particularly
initial
for
evidence.
orphan disease like this, I mean, it's not advantageous for them, so.
Exactly. So I think that, yes, this field will naturally develop, and for sure databases of, let's say, databases which make available the information about drugs together with, for example, off-label uses together with licensed uses will help in leveraging this complexity of information and to find potential solutions. So this is one step. I foresee, however, another step which is not near for sure, but it's the possibility to test in a combinatorial way the very say the very chemistry behind all the possible combinations, let's say, or all the possible modifications of one existing drug in order to create a new one. This is what let's say, if we want to test all the combinations, this is what in computer science is called an NP-complete problem. I don't want to explain what is an NP-complete problem, but I want to just make the point that basically it's a problem that exponentially increases in complexity while you start to test, to enlarge the pool of atoms and molecules that you want to put together and test. So we need frameworks that are different in terms of computation capabilities with respect to what we have now. And I think although we are at a very nascent stage, but probably what's most promising is quantum computing, which is basically using computers not in a binary state, but so as zeros, as one, as bits and bytes, but in a framework which is, let's say, theoretically completely different, because it's based on quantum mechanics, and enables us to basically test the different scenarios with the same computational resources at the same time. So what I see for the future from a computer science point of view is basically a big push that will be given first by machine learning and then by quantum computing.
Thank you so much. Thank you so much for your feedback. Thank you for your amazing speech. I think, again, this is like a wonderful model and method that will have to be a little better developed with good quality data as an input, and having indeed a lot of them, a lot of these. So thank you so much. Everyone is thanking you for the presentation. And well, everyone, you might receive a survey afterwards to just let Erika know how you like her presentation, and let us know how we could develop this webinar in the future. Thank you so much, everyone, for the participation. Thank you, Erika, for presenting this very interesting and challenging topic. And see you everyone in September. Don't forget, there is the NABIS next year, and so look forward to this meeting announcement on the website, as well as the IPBEIS, which is for the Pediatric Society. So thank you, everyone, and those that are looking for this next webinar, it will be most likely organized in September. Bye, everyone. Bye, Erika. Thank you again.
Thank you. And thank you to the IBIA for giving so much to my profession. I'm more than happy having given a 1 hour of my life back to all what I've received.